Okay, so I want to talk some about how families cope with chronic illness in general. Um, but in this context, we're talking about kids with congenital heart disorders. There is a lot of fear and anxiety, and that often doesn't go away. It's not, oh, I'm really scared because my child is sick, and then they're better. With an acute illness, once they're better, they're better. With a chronic illness, you're always waiting for the other shoe to drop, or you're always waiting for the next emergency. So there's a lot of fear and anxiety that just kind of stays and is there all the time. Parents with kids who are chronically ill also frequently have conflicting responsibilities. They may have other children to care for, they may have jobs, they may need to maintain those jobs in order to be able to provide for the child, but that job interferes with being able to care for a sick child. They maybe have other family members that they have responsibility for. So they have conflicting responsibilities. So they get tired, they're exhausted. I have been in a situation where parents, I've heard nurses be very critical of parents who are not present in the hospital when their child is hospitalized. And I have been in situations when I'm caring for a child as a nurse and the parent can't be there because if they miss any more time at work, they're going to lose their job that has the health insurance that's paying for that child to be in the hospital. So there's a lot of there's just a lot. There's a lot to have to deal with. Prolonged hospitalizations are hard on the entire family, and they affect development because of the separation from parents and other family members, and the restriction on movement. So parents with kids who have chronic diseases need respite care often. They need someone who can give them a break from that care. When caring for a child who is medically fragile, their discipline can be an issue. Sometimes parents don't want to discipline. They're afraid to discipline because they're concerned about whether they're concerned about their child's lifespan. And so they may spoil that child. They may let the child kind of do what they want, not make them do anything. So discipline can be an issue. And as those kids grow up, sometimes the parents are really anxious about allowing them to be independent. So overdependency is common. We also have to teach parents how to take care of these kids at home in between those hospitalizations or after the hospitalization. If they're on medications, some of the meds for cardiac issues, the dose, they have very narrow therapeutic range, and the dosage for babies may be tiny and an error can be fatal. So if, for example, we have a baby that's going home on digoxin, the dose of digoxin, the difference of 1/10 of a milliliter could be deadly. So we've got to make sure that they know how to give those medications, how to assess the heart rate, and how to measure those meds properly and give them. And so they need lots of opportunities to learn that. And as discharge is nearing, frequently the parents are asked to give those meds with the nurse's supervision. So the nurse does it, the parent watches, the nurse and the parent do it together. The parent does it, the nurse is watching, so that when they go home, they have that skill. They've learned how to give that medication. With shorter hospitalizations, that's gotten more difficult. They also need to know about other treatments that the child may need. They need to know about follow-up, when and where follow-ups need to happen. They need to know what it's going to look like if their child has a complication or is getting worse. So what does worsening hypoxia look like in a baby? What does worsening heart failure look like in a baby? What should tell that parent, hey, we need to go back to the hospital? They need a lot of teaching about nutrition. These babies don't have energy to expend. And so a lot of times we do things to try to make it easier for them to eat. So they might have a nipple with a larger hole. Then you have to be concerned about some aspiration. But we need to be teaching the parents how to feed the child and how to monitor for adequate growth. All of these kids are at risk for failure to thrive because they're using all their energy to stay alive. And we need to make sure they understand which immunizations that child needs and when. Immunizations are important because an infection that might be mild for someone else can be deadly for these kids. Parents of children with chronic illnesses are going to have relationship with medical providers. We in healthcare frequently we really like it when patients and their families listen to us and do what we say. If you have been a patient or if you have been a caregiver for a patient, you will learn pretty quickly that you have to advocate for your family member or for yourself because the system doesn't always work as it's supposed to. So parents of chronically ill kids learn to be advocates for their kids. They learn to stand up and say, wait, why are we doing this? What's that for? No, I'm not going to do that. No, I'm not going to allow that. And so sometimes that relationship can get adversarial because they're advocating for their child and we're just trying to get our work done. So they're more likely to feel more confident in speaking up and asking questions and advocating. We want to encourage that. We want to encourage them to advocate for their child. So we need to develop a relationship with those parents of trust, meaning that we trust that they understand their child and we show that we are trustworthy to take care of that child. Development can be impacted by chronic illness, social development, because there's not a lot of opportunity for interaction with other kids if you can't leave your bed. So when they're super, super sick, can't leave that hospital bed, that's a factor. So in most pediatric hospitals, they actually have rooms where kids on that unit who are stable enough can go into the playroom and meet other kids. We want to encourage parents and help parents find ways to give their kids interaction with other children. However, right now we're in a pandemic and that affects social interaction for all kids. How much more does it affect interaction for kids who are particularly fragile? Cognitive development is affected by the environment, just the stimulation they get, but also by hypoxemia. If we're not getting enough blood to the brain, either chronically or in episodes, that affects cognition and then other comorbidities. Physical development is affected by feeding difficulties and failure to thrive. Invasive procedures, heart disease by necessity involves a lot of invasive procedures. They're painful, they're scary, and we're doing this to very small children typically. So how can we help them cope with those procedures better? Pre-procedure teaching needs to be done for parents and the child based on the developmental stage of the child. Okay, we talked about that a little bit earlier. Younger kids should be told closer to the time that it's going to happen. And so maybe a toddler, you tell, okay, today we're going, or maybe tomorrow. Preschooler, you probably do tomorrow or on this day. By school age, you want to give them a week or so to prepare for the idea. Adolescents, you want to tell them when you know. We want to focus on the child's developmental age with that information. What will they experience? What will they need to do? And what will be different afterward? Okay. We want to emphasize comforting areas. Tell them the things that we're going to do and show them the things we're going to do to make it less scary and less painful for them. Post-op, for any kind of heart procedure, we're monitoring vital signs, including blood pressure. Remember, we don't always do blood pressure on those kids under 3 or 4, but for heart kids, we do. Okay, blood pressure. Auscultate the lungs hourly, manage their temperature. They may be on a vent. They need to be suctioned very carefully and only as needed. Only suction if they have stuff that you can hear that they can't get up. Arterial lines, they usually have an arterial line for blood pressure monitoring. They commonly have central venous pressure monitoring them. So they may have big lines in the chest. They may also have a peripheral IV. If it's an open chest procedure, they're going to have chest tubes. Chest tubes are painful while they're in place, and they're painful to remove. So we need to pre-medicate kids before those chest tubes are removed. They're on strict I&O. They may have a fluid restriction, and they need rest as they're recovering with progressive return to activity with really close monitoring. Lots and lots of comfort and emotional support and adequate pain management. Discharge planning begins at admission. So from day one, we're planning for what supports is this child going to need at home? What supports will the family need? Teaching the family what care that child's going to need and making sure that the environment's going to be prepared. Okay, in the next section, we're going to start talking about some acquired cardiovascular disorders, things that you're not born with, they happen later.